Hi, I'm Dr. Petros Benias, and I'm here with Dr. David Carr-Locke. And I've had the privilege of working with him and being trained by him for many years. So I think I get the honor of asking you some questions today.
Please do.
Yeah. So I think I know a little bit of how it all started, but it's always good to know all the details. So, how did you really get into this?
Well, I actually started training as an obstetrician first, which probably most people don't know. And then I didn't really pursue that, maybe because there was no laparoscopy at that time in the early 70s. And so I went back into internal medicine. And I had done a GI job as an internist and as my first year of residency. And I had obviously got the bug, even though the scopes were terrible at that time in '72. And I ended up in a new medical school in the middle of England, and there was clearly a need for GI because there wasn't anybody. And I thought, well, maybe this is my niche after all. So in 1974 and then into '75, I started doing GI pretty much on my own. I was with one senior physician who had done some endoscopy, but if you compare that to how people get trained today, it's totally different. So I was very much on my own, which was great for me. I had a great time scoping most of the city, which was at least 1 million people. And over the years, really got hooked on how endoscopy could make diagnoses at that time and then become therapeutic. And that's, of course, what my career developed into. And during that time, I was there from '75 up till '89 when I moved to the States. We developed 3 separate endo units in different hospitals and got a huge experience doing things that either had not been done before or certainly not done in that area of the UK.
Yeah, I always find it interesting because everything about what we do now is so structured. The fellowships, the milestones we should all be reaching, but you guys had no idea what you were doing early on. I mean, and then you published landmark studies in ERCP. I mean, how did you learn how to first do this?
Well, I learned early on that my colleagues would be surgeons.
Yeah.
And that, of course, that's the same today. But it was, at that time, I really was on my own as a non-surgeon doing fairly risky procedures that we really didn't have much track record on. Even taking out stones from the bile duct was a new thing in 1975. And my allies were the surgeons. And strangely enough, the most senior surgeon in the hospital I was in could see that this was so much better than what they'd been doing for decades. Much safer, more effective. And some of the randomized studies we did were because of him. And
Right.
as many will know from my publications, many of them were done with a Greek colleague, John Neoptolemus, who's now chair of surgery at Liverpool University in England. Okay. But all the other co-authors were also surgeons because that's where I worked. They got the patients because there was still the tradition that most biliary and pancreatic disease went to surgeons. Right. And I was able to have access to those patients and treat them.
Can you just give us a little bit of the details of those early days of ERCP? Because I think it was like the Wild West of endoscopy back then.
Yeah, well, it was wild in some senses. I mean, remember our scopes were fairly primitive. They were optical, so we had to do this, which meant that only I could see, so I could say anything I wanted.
Just made it all up.
So optical instruments, non-insulated. The tip of the duodenoscope we used early on was metal. We figured out a way of not electrocuting ourselves, but I did lose my right eyebrow a few times from burns. We had very few therapeutic instruments. We had a sphincterotome that was handmade in Germany that I used repeatedly until it didn't work anymore. The generators were available, so that was good. We had very few extraction devices, most of which we borrowed from our urology colleagues, the balloons and baskets we adapted, because there were no endoscope accessory companies at that time. They came later. So you're right, we didn't really know how successful we would be, and I do remember my very first ERCP. Remember, this is an endoscopist moving into the radiology department. That was unheard of. And so they wouldn't let us do that. We had to find the papilla and cannulate it before we could actually go to the x-ray room. So, and move the whole patient and equipment. Wow. So we did that once. I didn't do that again. And I mean, that was a crazy idea, but that was the sort of resistance to something new like that at the time. And then they begrudgingly gave us a room for an hour or two, and then it became half a day, and then it was every day. And I remember in our first years, we would do 6 to 100 ERCPs a year.
Wow.
Just me, because this was an untapped population of patients, and they all needed to be seen. So that's how the experience grew so quickly.
So you're working with surgeons, you're stealing technology and ideas from urology, you're innovating as you go along. So yeah. You've seen the whole spectrum.
Yes.
So what are the innovations and the milestones that just changed, that I take for granted? What's changed everything for us?
Yeah, so you're right. I think certainly fellows being trained today don't know what's gone before because they haven't experienced it. And reading about it doesn't give you the same sense of how it was. So, you know, the early days I just mentioned, and as technology changed, our image improved. One big change, of course, occurred in the mid-'80s when optical instruments became video instruments. So that actually other people could see what we were doing for the first time. That was a good thing and a bad thing. You couldn't hide anything anymore because it was out in the open. But in general, of course, for a teaching hospital, it was a fantastic improvement. And although the image was actually not as good electronically as it had been optically, that improved to what we have today. So that was a big change. And then as the accessory companies developed, we then had more and more instruments. So we stopped borrowing guide wires from the radiologists. We stopped stealing instruments from the urologists. We had our own for the first time that were purpose designed. And they didn't always work very well, but that improved over time. So that also became a big part of the development and allowed us to do more and more things. And then, you know, if you're interested in this area, you start to think, well, how can I achieve certain thing? How can I solve this problem? Why can't we do this a different way? And so that interaction between the clinician and industry starts to develop. And many of us started doing that in the 70s and 80s, and that's continued for me to the present day, as I think that's part of our makeup. And I know it is for you too. It's what interests us in solving problems.
So, I mean, I know you know on a personal level, and you know, many people would say, oh, is David slowing down at all? Oh, no, he did a food impaction last night at 3 a.m. And one of the funny things is I've always known you to sort of kind of lead by example and take call like everyone else and kind of roll up your sleeves and do that. Yeah. You know, I think I always was impressed. What keeps you evolving? Like, what's driving this? Like, what, you know, because you're doing so much and you're constantly reinventing and you're looking for what's exciting.
Well, it's not drugs and it's not alcohol. It's I think those of us that do this sort of therapeutic work, and it's not just ERCP, it's a whole range of things now that we can do, as everybody knows. Those have always intrigued me as ways of solving problems for our patients without open surgery, as it was in the beginning, and now without other alternatives. That's been a stimulus, and I've always wanted to do as much as I can in that area and help develop if that's the way it went. I just enjoy doing endoscopy. I got the bug early on, as I mentioned, and I've never stopped. But I think I'm a doer, so I won't sit back and let something go by if I can help do it. It doesn't matter what time of day it is. I still take call, and my colleagues, you know, where I am now know that I still work pretty hard. Yeah. But it's fun, and I've always said I'll stop working when it's not fun anymore.
Harder than some of the fellows, I think.
I think I work harder now than I did even 10 years ago. Yeah. But it changes, you know, and the teaching other people how to do what we do, and that changes too, and of course the recipient changes each year. Right. I think that's all part of what we enjoy doing. But the end result is a patient who, you know, survives something, recovers, and goes home, and that's always the best. That's the best prize of all.
So what is what are you most excited about these days, technologically or conceptually? Like what is the next 10 years?
Well, I think, if you look at the evolution of the technologies, and now it's many, it's not just the scope itself, it's everything that goes with it. If you look at how it's being used and what disease processes we now treat, the field is so different now, even from 10 years ago. And I think back, often a fellow will say, well, when did you start doing whatever it is? I couldn't conceive that we'd be taking out large tumors from stomachs and colons 20 years ago. It just wasn't possible. And now we do it regularly. So I think, will that continue? Yes, of course it will continue to develop. We will have more and more tools that will help us do that more readily and efficiently and safely. And that's good for everybody. But I think undoubtedly we'll be doing new things that we don't do at all right now. And you can see the beginnings of things like full thickness resection that we sort of try to do with the tools that we have, and they're not quite there yet.
Right.
And I think what will happen is the technology will develop, again, jointly between us and industry to achieve things much more safely than we can now, and maybe not at all. We'll go places we haven't been. The notes area didn't last very long, but I think it was an intriguing idea that we're going outside our comfortable space into a place where we're not supposed to be to do things, and it didn't quite succeed, although it generated a lot of the tools that we still use today. I think we may see some of that come back again, provided that we can prove that what we're doing is better than the alternative. And you have to remember that we're not the only ones that have evolved. Surgery's evolved, interventional radiology's evolved, and so those other aspects of therapeutic care have allowed us to do things more safely and without open operation. And some of those things are actually better than what we do. And I think people mustn't forget that we've got to keep that in mind. Those things are maybe just as good, sometimes improved, but have to be compared.
Right, because of course, it's sort of, we make the comparison with the early days of ERCP and stone extraction. We were dealing then with a procedure like biliary exploration that was not very good.
Right.
And we were offering a service, and I think we have to stay innovative, but we have to keep that perspective.
Yeah.
What advice do you have for the fellows that are starting GI fellowship now and they're interested in therapeutics?
So I think, all GI fellows eventually end up being endoscopists. That's the way training is arranged, and that's great. But within that whole group of endoscopists, I think there's natural selection of those who want to do the sort of things that we do therapeutically. And then even within that, there are different levels of skill and interest. Not everybody ends up doing the same thing, and that's fine. And the people that, if you're asking me about advice for somebody who wants to do advanced training and the therapeutic aspects of endoscopy, is to get the right training,
right.
Which I think is the starting point for seeing all of the wonderful things that we continue to produce and offer patients. And then to keep thinking, well, how can I improve something? Never stop. Don't accept what the status quo shows you. Even today with something relatively new like POEM, there's always some way you can improve it, but question why it's being done that way. It was done that way because somebody somewhere decided that this is the way it should be. Right. It doesn't have to be done the same way, and you can see that repeatedly happening throughout our specialty over time. So question everything. There's nothing wrong with that. Try and improve it if you can, whether it takes a new technology or a new device or a new way of doing something. I think that's the role of each generation. You have to work hard. You can't go home at 5 o'clock every day and hope that that's all going to happen. I still work long hours, for whatever reason. That's the way it's been developed over the years, and nights and weekends are the time that you read and write, and those things are still important. Publishing what you do and publishing it well are a way of showing that you understand what you're doing, that you ask the right questions and you answer them, or you try to. And I think that's sometimes forgotten in the enthusiasm for learning skills, you forget about the fact that you have other roles to play, and that's to document what you do and to try and research the field.
I want to say thank you to Dr. Carr-Locke for all the mentorship he's provided to me and to all the other fellows and people he continues to train. And thank you for being honest and telling us how you feel about all this. Great.